laser. Okay, what are you going to do for the patient with psoriasis? You know what it looks like. Now what? Well, it totally depends upon the extent of it. I mean, is it covering a few areas? Is it over the entire body? Is it disfiguring? You know, how upset is that, not how upset the patient is, but like, is it impairing their, you know, quality of life? And if so, you're going to go to more aggressive measures versus somewhere or someone who it doesn't, you know, it's not that big of a deal. Say they work a desk job and they're on the phone and they're not making sales or closing big contracts in sales, where you would need to look less disfigured. That sounds bad, but it's the truth. Well, also we want to factor in is how the patient responds to the psoriasis treatment. So you got three things that you're looking at that decides what kind of interventions you're going to do. Patient's distress, the extent of the disease, and the response. Make sense? Yes. So first things we want to do is apply a topical steroid directly to the site of where the psoriatic lesion is. You don't want to apply it, you know, to areas, you know, just all over, just to the area where the lesion is. We do not want to apply the topical steroid to somebody's face. I know that they may have lesions on their face, but this is not a good idea just because, well, I believe it can actually make, because the skin on the face is extremely sensitive, and if you apply a topical steroid, you're going to elicit, you know, a reaction of some sort. So the skin will thin down, it will break down, and you're going to probably have like a redness there. So avoid topical corticosteroids on the face. We want to make sure that the person can apply this. In fact, when they apply it just on the lesion, that they also add a warm, moist, occlusive dressing, and to wrap up their lesions with, say, saran wrap or a towel, anything. This will actually help the medicine absorb deeper into the skin and be a little bit more effective. And this can be done up to about 8 hours a day. So that's a little tip if somebody is having trouble with the lesion. So apply a warm, moist compress, wrap it up, you know, or put your foot in some socks or booties. If you have, you know, the other kind of psoriasis, the palmoplantar kind, and let those corticosteroids work for you. The next thing that somebody can do is apply tar preparations. That sounds quite odd to be applying coal tar to your skin and to your body. However, studies have shown that it has decreased the severity of the psoriasis plaques, and I mean, it does help. Another type of coal tar, it's a derivative of it, is called anthralin. So you'll see some patients get prescribed this anthralin, which acts like coal tar. And this is for moderate psoriasis, not for just mild little bits here and there. So when people get a little bit more lesions, they can use this. Now, the thing about the coal tar is that it is very messy, it stains, it smells, it kind of has like a sulfur smell, very unpleasant. You know, it can come as a solution, an ointment or a lotion, or even a shampoo if they have it in their hair. But it's not exactly something that will go unnoticed, I'll say that, unlike your topical steroid. One more thing about the tar preparations is the anthralin. This comes in like an extremely thick paste, and you want to make sure the patient applies it directly to the, you know, psoriatic lesion, not anywhere else, because it is a irritant to normal skin, and it will actually cause some redness and like a burning sensation. So make sure that the person puts it only on the involved skin, nowhere else. Let's see. The next drugs that we have here for psoriasis are the topical epidermopoiesis suppressive medications. Particularly, I'm speaking about the one called ZahraTeen, or Tarzarac. So this is a type of vitamin A. Well, it's actually, I shouldn't say type of vitamin A. It's a it's a vitamin A derivative, so it's from vitamin A. So if your person has got mild to moderate psoriasis, this would be a good option of choice. You can apply it right to the area, and it will actually reduce the development of epidermal cells, like their rate of growth. It will kind of suppress it, so that's definitely a plus. However, if somebody is breastfeeding, or if they have potential to become pregnant, we definitely don't want to use this because it is a teratogenic drug. So they want to use they want to use 2 methods of birth control. Let me just add one layer of thinking here. So if I were to throw a question out about somebody being on Tarzarac or that ZahraTeen, and you know in your mind the problem with becoming pregnant and needing contraceptive, would you put 2 and 2 together that before starting this medication you want to obtain a pregnancy test? Maybe, maybe not. Try to think of things in that matter. So if I say pregnancy, bad for the baby, and we're evaluating somebody to go on this medication, think a little deeper and say, do we have a pregnancy test? Is it negative for this person before we start this therapy? Just a little FYI. Moving on to some cytotoxic medications that you can give to patients. Now, only should cytotoxic medications be given if the case is severe. You don't want to give it for a mild to moderate case of psoriasis. So this person has a significantly decreased quality of life, the psoriasis is out of control, they're having frequent skin infections that can be prevented because their skin integrity is broken down. You have to move to the side. You have to move to the big guns, basically. So what drugs are we looking at? Well, the first one that comes to mind is methotrexate. Looks like methotrexate does a lot for people who have autoimmune conditions, so keep that one in the back of your mind. But yeah, methotrexate is one that we used. This is great because it reduces the turnover of epidermal cells. So no longer is it, the 4 to 5 days, it actually is going to slow down a little bit. Now, we want to monitor the liver functions for folks who get methotrexate because it can definitely cause liver toxicity and in a very short amount of time. So if our patient has a bad liver, well, probably not a good candidate for methotrexate. They'll have to get another type of medication to help their immune system calm down. The other bad side to methotrexate is that it causes bone marrow suppression. Like most chemos, it's going to wipe out the fast-growing cells and slow them down. So we're looking at leukopenia, thrombocytopenia, anemia. So this person's going to be at risk for infection, risk for bleeding, and also, when you're at risk for anemia, you have, probable chest pain, tired, fatigue, things like that, hypoxia. So this person, what are you going to teach them? Well, things for bone marrow suppression. Report a fever. I'm talking a low one, like 100, 100.1, 100. If they have a sore throat, if they have increased bleeding or bruising or fatigue, those are all signs and symptoms of either leukopenia, thrombocytopenia, or anemia. Boy, those are a tongue twister. Dear Lord. So some other things that we can do is ultraviolet light therapy. They call it PUVA therapy. So in lupus, we tell patients to avoid the sun, run, hide, don't come out between like 10 and 7. But for patients with psoriasis, we need them to have exposure to ultraviolet light. Yes, that means get them out there in the sun. Now, this P here stands for photochemotherapy. So what they do is actually give a patient some kind of photosensitizing medication. The cells absorb it, and whenever the ultraviolet light is administered or over the skin, believe it or not, the cells begin to slow their production. So definitely beneficial. When we have a patient and we're working with PUVA therapy, you actually give the medication about 2 hours before their ultraviolet light treatments, and you have to do this not, consecutive days, because you got to spread it out. You're going to burn the patient's skin, and this sounds weird, but you want to get them to a nice tan color. Your patient shouldn't be overly reddened, and then they shouldn't be overly pale. I want to say pale, but people of different ethnicities, they shouldn't be too light. Medium rare, please. So that being said, check the patient's responsiveness to the light therapy. Are they excessively red? Is the skin tender? Do we have that nice tan color? That's how you know you're doing it just right. If you're, making the patient too red or they're getting blisters, well, got to back it up. Less treatments per week. Now, PUVA does increase somebody's risk for skin cancer. That's probably a no-brainer, but I just want to pull that to your forefront of thinking. Also, when you get in the sun, how about your eyes? You're probably going to have at risk for cataracts. So just some things to add to your repertoire of knowledge. Last but not least are other systemic medications. So what could I possibly be talking about? Well, one of the very first ones is your immunosuppressants. These, is a last resort whenever some person with psoriasis has lesions, they're not responding to anything, the light therapy, the cytotoxic meds, well, you're going to have to do some immunosuppressants. So this person, yes, is going to be severely immunosuppressed. The drug that comes to my mind is Sandimmune or cyclosporine. That's one of the top drugs that you'll see. In addition to cyclosporine, there is a new class of drugs that are being marketed actually in your TV screens right now. Humira, you may have thought of that one. Enbrel, that one's coming up, and I think one of the newest one is Stelara. Those are the new biologics that are going to be actually probably first-line treatments for folks who have severe psoriasis, excuse me. And these, I believe, are given by, sub-Q injection. I think, well, how often do you do these? I want to say once a week that patients have to get those biologic agents. So some of the things we want to teach our patient, because they are going to self-administer this in the home setting, how to rotate sites, how to give themselves an IM injection, make sure you go in at the right angle, where to go, what to report, some signs and symptoms of reactions. One thing about biologics is if a patient is pregnant, these are a no-go. No-go, no-go. So I guess we're getting to a lot of medications here for pregnant people. No for pregnancy, and no. Or breastfeeding, that kind of goes in the same category. Last but not least, your patients who are getting these immunosuppressant drugs here and here, how about vaccinations? Should they get vaccinations? Are they eligible for vaccinations, particularly live vaccines? Yes, no? Actually, no. This person does not need to get a live vaccine. Just in case you were wondering which one of the vaccines are live vaccines, some of them you can actually get, you can request the alternative, which is not a live vaccine, but majority of the ones that are live are like the MMR, the measles, mumps, and rubella, the polio vaccine, also the herpes zoster, for what is it? Like shingles. The shingles vaccine is the live vaccine. So varicella. Those are the ones that are the live vaccines. You don't need to know that for the test. That's just for kicks and giggles information. I can't walk away talking about the emotional aspects of psoriasis. So you do understand that it affects somebody psychologically, heavily, let me rephrase that, it heavily affects somebody psychologically, because this is what they look like. And that's very hard, knowing that under, you know, all of the makeup and cover-up that we put on, you know, at the end of the day, this is who they really are. It's kind of like a you know, Dr. Jekyll and Mr. Hyde kind of look, but to help a patient's self-esteem, definitely direct them and the family members to support groups. Honestly, this is one of the best things you can do for somebody, because they can live the experience and help avoid some certain struggles by sharing their stories with other people who are suffering from the same condition. So support group reference is very big. Now, the book highlights something in particular that I just want to disagree with. So it states, for patients with psoriasis, do not wear gloves during these social interactions. Touch it more than any gesture communicates acceptance of the person's skin problem. Okay, many of the times when you're in the healthcare setting, you may just naturally put on gloves. I am okay with that. NCLEX wise, okay, you're going to not put gloves on just because these patients are not contagious. And you know, they are valuing psychological effects of wearing gloves. But just in general settings, you may or may not know that they have psoriasis, and this, you know, who knows what that is. So wear your gloves when you're in clinical settings. But for NCLEX, you will not wear your gloves, because you want to provide the person that you understand their condition is not contagious and that it's just extra flaky skin, that's all. Now we're going to cover a few skin lesions. So we're moving away from the autoimmune conditions and we're talking specifically just about skin. We're going to cover acne, eczema, contact dermatitis, drug-induced dermatitis, and atopic dermatitis. So by the time we're done with this, you'll be able to know what causes one, how to treat it, and prevention measures as well. What I have here is a nice variety of pictures. Some of them can be quite gross. In fact, as I was selecting pictures for the slides, I think I vomited a little bit in my mouth. I'm going to actually not look at that one because it makes me a little queasy. Okay, macules. So when we say macules, the first thing that comes to my mind is I think of a mat. They're very flat. They you know, have borders and not much to a macule, or just know that it's flat, and it can be reddened, but mainly flat, like a mat. Then you have papules. When I think of papules, it kind of reminds me of pimples, but the thing about papules is they're not fluid filled bumps. They're literally just bumps, and that's what brings pimples to mind. But here we have a bunch of papules on this person. They're reddened papules. There's nothing filled inside them. They're just kind of hard knots on somebody's head. And some vesicles. Now vesicles are fluid filled. They can look like blisters. Well, yeah, basically blister is a vesicle. So they're just fluid fills, raised bumps, and they can be red. And I actually found a great description as I put this slideshow on pause on page 423 of some of the different skin eruptions that you can have. But for papules, I've got here, they are small, firm, elevated lesions, less than 1 centimeter in diameter. So it's always good to know. Here we have eczema. Unfortunately, this is a pretty bad case of it. It's all over the neck. And acne here is what you're looking at. In fact, I was reading a story on this girl that it was deceiving and deceptive to cover this much acne. I don't feel that that's the case. In fact, however you want to represent yourself, go for it. But in fact, some of the comments was that this lady needed to be like, one of the very first dates with girls should be swimming, and obvious reasons is that it would wash all the makeup off. But anyway, don't be a hater. I support her. because that's pretty bad. One of the other skin lesions that we're going to reference is the pustules, which is what you see here on this young child. So these would be pus-filled, and if they're deep, they would be cyst. Drainage here is cloudy and purulent. Okay, now that I've grossed everybody out. Alright, so acne vulgaris. We are looking at the most common skin disorder in the US. What happens is that oil glands near the hair follicles become plugged, and unfortunately the production of oil can harbor bacteria, and so you'll get these red inflammatory areas on patient's skin. It forms a plug, and sometimes they can actually be deep and cyst-like and disfiguring. So first thing we want to do for patients who begin having signs and symptoms of acne, you know, like the redness and the pimples and the, oh, what's the fancy name for them? I can't think of it now, but blackheads. First thing you want to do for them is get an over-the-counter or a prescribed cleansing agent. One of the most popular ones is the benzoyl peroxide. And this can be applied to your face or even back in like a cream, a lotion, or a gel, like once or twice a day. So this is one of the first things that you can do for mild acne. Salicylic acid. In fact, sometimes you'll go to a wow, I'm really kind of slipping on my words. Where you go and get massages? Ugh. What are those called?
You go to a masseuse.
No. Alright, hold on. Oh, this is sad. I couldn't think of the word spa, actually, because sometimes they have facial treatments they can do, and they can also, they can perform a salicylic acid peel on your face, a chemical peel, and this helps reduce some of the breakouts that patients have. Now, we want to make sure our patients don't vigorously scrub the skin. It is tempting, however, this can cause more irritation. So stay away from vigorous scrubbing. I cannot repeat that enough because it may be testable material. Stay away from vigorous rubbing. Well-balanced diet, there is no correlation, there's no evidence-based data that says what you eat causes or decreases the amount of acne. However, they encourage a well-balanced diet. And stress. We can all vouch for that. Whenever we are more stressed, we have more breakouts. So if a person who's dealing with acne can control their stress, they're probably going to have better clear days, as we say. And we have some other topicals. Now these are all prescribed drugs that a patient can use to control acne. And well, what do we have here? You just saw that drug, the ZahraTeen, that vitamin A derivative. It actually helps psoriasis patients as well as those with acne. So just kind of keep that in the back of your mind. It has multiple things. In all of these drugs up here, we can actually have a little bit of what's the word? Photosensitivity. So whenever they apply this to their face, and you know, once or twice a day, they need to be careful, because if they get in the sun, that certain area where they applied the gel or the cream or the lotion will burn. In fact, it won't just burn a little bit, it will they'll turn out in blisters. So we want to remind our patients to be very careful of covering their face, you know, with a hat, glasses, sunscreen. Okay. If the acne is not controlled by topical methods and diet and stress reduction, then you move to plan B, the oral antibiotics. And we do remember these drugs, the doxycycline, the minocycline, and the tetracycline. Those are the drugs that we learned about in part 1, so you can review that if you need to. But these are great because they systemically can control acne. They are bacteriostatic. one thing we want to make sure is that the patients are not pregnant. Make sure your patients are not pregnant whenever they go on these type of drugs here. And for erythromycin, this is known as the substitute for tetracycline in the event that somebody has an allergy. And I do believe the tetracycline, yeah, the tetracycline and the erythromycin can come in topical forms, and those are very well tolerated generally and have reduced side effects. So for severe cases of acne, we look to this drug, isotretinoin, or amnesteem. This is the last resort for somebody who has such severe acne that we have to put them on this drug. It has some pretty serious side effects, like skin irritation. I mean, it seems like most topicals have that. However, this can be accentuated if they're on if they're taking vitamin A or tetracycline. Definitely have a higher chance of having like skin burns. They can also develop like thrombocythemia and have nosebleeds. Cannot take this drug and not have any kind of contraceptive use, like two methods to prevent contraceptive. This is pregnancy category X, and it will cause fetal harm, congenital defects, or fetal death. So they have a program that we're about to talk about to help support and make sure patients who are on this drug do not get pregnant. The new program is called iPledge. This is a internet-based registry where anytime somebody is prescribed this, the provider, the pharmacist, and the patient must be registered with the company that creates this medication. And it's supposed to help reduce the risk of having complications, or not complications, reduce the chances of somebody being pregnant while on this med. So a lot of people involved in the iPledge. And before somebody has a drug that's possibly teratogenic, what are you going to draw? What are you going to make the patient do? What kind of lab test? I really hope you're saying negative pregnancy test. In fact, you don't need one, you actually need 2 negative pregnancy tests before a patient goes on this drug. And on top of that, you have to do, I believe it's monthly pregnancy test. Let me verify that. Yep, verified it. Before every refill, a person has to go and repeat and have a negative pregnancy test. They are that serious about this. In fact, I really think this is a great program. Why we don't do it for every drug that is teratogenic, I don't know. Probably because they understand this drug is mostly going to be given to young teenagers who have sort of a immune mindset. Nothing wrong can happen to them, and they may have risky behaviors. Okay, next. So the first kind of dermatitis we're going to talk about is drug-induced dermatitis. This is when somebody is ingested a substance. There's a couple different types of drugs. It's not exactly important to know that somebody can, or what drugs somebody can ingest to cause this. I mean, really any kind of drug. You can get a drug-induced dermatitis. This is just how we classify it. And what it looks like is they have a pattern of a rash. Depending upon the drug, it can be just on their trunk, just on the extremities, or on their face. It really just depends on the drug. Urticaria, that's fancy for hives. So a person is going to break out in a rash and hives and papules, if you remember those. I mean, I know I mentioned pimples, but it's not pimples, but bumps. Bumps is what I want you to think of when you think of papules. And vesicles. Vesicles are the fluid-filled, like bumps, and those can just occur everywhere, and they can be in specific patterns. Now, there are life-threatening drug-induced dermatitis, and these are like head-to-toe eruptions, the erythema multiforme. This is over a large portion of the body, And the main thing with this, with all of these drug reactions, take care and obliterate whatever drug is being given to the patient. So if you start noticing, some kind of dermatitis and they're receiving multiple drugs, particularly antibiotics, well, stop the antibiotic and this will go away. Don't continue to give them the antibiotic. And if you notice this, I will say there's a very good and thorough chart that I want you guys to be familiar with. It's chart 25-9 on page 455 of your Iggy book. That just has the down and dirty version of everything that I'm saying here. Dehydration. If a person has this and it has the severe life-threatening version, it puts your person at risk for dehydration and hypothermia. Depending upon your patient's underlying condition, this can be a big problem for them. Alright, here we have another type of skin inflammation, is the contact dermatitis. What does that mean? Well, it could actually be an acute or chronic rash, but it is caused by direct contact of some kind of irritant, some kind of allergen. And this results in a immune response where the skin reacts, and it's only localized. So here we have somebody who has got an allergy to some type of ingredient in cosmetic, some eye makeup. Here we have poison ivy. That's a form of contact dermatitis. Nurses actually can get contact dermatitis from washing their hands so much. The skin in between their knuckles and on their knuckles will actually break down and get red and rashy. Let's see. Oh, and this is from nickel. These patients have allergy to nickel. So it's just localized. Get rid of whatever is rubbing on or whatever their skin is exposed to, and you'll get rid of the contact dermatitis. However, sometimes it's not always possible to get rid of the offending chemical, such as washing your hands and you have the soap. So sometimes you have to move to non-pharmacologic measures. I know for any of you who are going to be getting a career in the operating room or in the NICU, your hands are at big risk for contact dermatitis. So be on the lookout if you start developing, because you'll want to catch it quick and start doing steroid therapy. This is where you apply a topical cream over your hands or the area that's breaking down, and it's very good in that it helps suppresses the inflammation, the localized inflammation that you're having. If it's so severe, they may even give you injections of the corticosteroid, or they'll give you a systemic pill. Hopefully that's not the case, because there's lots of side effects with systemic medication, but localized steroid therapy is the key here. And I will say corticosteroids do not cure it. The only way to cure contact dermatitis is to avoid and go away from whatever is causing the rash. I want to add one more thing about the steroid therapy. As you remember, in psoriasis and even in the lupus, whenever you apply corticosteroid therapy, how do you make it absorb better? Well, you do warm, moist compresses and wrap it with saran wrap, about 8 hours. Well, I should probably add the little caveat. For this, just contact dermatitis, you do have to have a doctor's order that says you can wrap it. For the other conditions, wrap it. For this one, make sure the doctor said so. Another thing we can do is calamine lotion. This is great because it actually has a little bit of antihistamine on there. It doesn't give much relief to somebody who's been exposed to poison ivy. However, it does help a little bit suppress the histamine release. So if you can, get some Benadryl cream or some calamine lotion and rub it on somebody who's got some contact dermatitis. Little soothing effect there. Oh, and it has the added benefit of debriding the crust and scales. The The last thing we're going to talk about is the atopic dermatitis. What you're looking at, like right here, is what we call lichenification. So that's fancy for hardening of the skin and like a leather-like, appearance. So lichenification, and it's going to have also some scaling and some excoriated area. As you can see, that's kind of excoriated there and there. Extremely itchy. It is just ridiculous. And the patient will actually continue this cycle of this type of dermatitis by itching it. It continues to form scales and it's excoriated, and like the cycle continues. Thing about this is it's a chronic rash, and it generally occurs with allergies. So if somebody has some like seasonal allergies, unfortunately they can have a skin eruption if the immune response is so severe. Also stress. I'm thinking this is somebody's leg, like this is their thigh and that's the calf. That's a pretty severe version. This is on a African American male.